Lastly, to consider second and third line options, we know that both nivolumab and pembrolizumab, both are anti-PD-1 antibodies, have accelerated approval as single agents in second line post-sorafenib HCC. Those accelerated approvals were in the post-sorafenib era, based on single agent activity with response rates in the 15 to 20% range for both of these agents and durable responses. One of the challenges, though, is that the Keynote phase 3 study, that was the validation study for pembrolizumab post-sorafenib and randomized patients to pembrolizumab versus placebo, was not statistically significant, so did not reach statistical significance as far as overall survival. The study had shared endpoints of co-primary endpoints of overall survival and PFS, and had multiple interim looks. So a lot of the power of the study was spent on that. And to meet statistical significance, the p-value had to be below 0.0174. And the p-value was actually just above that as 0.02. So even though the curve separated, the median OS with pembrolizumab was 13 months, with placebo it was 10 months. So we know there was clinical activity for pembrolizumab. It did not reach statistical positivity, statistical significance, and thereby by definition is a negative trial. Now, to complicate things further, it's important to note that if a patient is treated with atezolizumab and bevacizumab, it would not make sense to go to nivolumab or pembrolizumab because the patient has already progressed on anti-PD-L1 therapy, and we have no evidence that switching to anti-PD-1 therapy would actually have activity in that setting. The last second-line option I would mention is the combination of nivolumab and ipilimumab. This has also received accelerated approval in 2020. This was a cohort of the Checkmate 040 trial in which three different dosing and schedule combinations of nivo and ipi were evaluated. The combination that received accelerated approval is with nivolumab 1 milligram and ipilimumab 3 milligrams per kilograms every 3 weeks, given together for 4 cycles. And then patients are maintained on nivolumab single agent. The response rate, the objective response rate based on RECIST 1.1 was in the 30%, low 30% range for this combination. And the median overall survival post-sorafenib was an impressive 22 months actually with this combination. Now, all patients had Child-Pugh-A and a good performance status. It's also important to note that with this combination, there is a higher risk of toxicity and immune-mediated events. So the grade 3 and 4 events occurred in 53% of patients, and roughly about half the patients had to have steroid for immune-mediated adverse events. Of course, the most common ones were dermatitis, but there was also some colitis, hepatitis, and pneumonitis. So this is a combination that has to be given to the right patient, and the patients have to be managed carefully to ensure that they can tolerate it and are treated adequately. In regards to alpha-fetoprotein, especially in the second-line setting, it is important to note that all the agents that I covered analyzed their data or had an analysis of the studies that led to their approval based on AFP above and below 400. And it's important to note that all these agents were noted to have activity independent of AFP level. Regorafenib, the anti-PD-1 antibodies, as well as cabozantinib. For cabozantinib, there was an additional analysis that looked at AFP response and showed that the frequency of AFP response was significantly higher in the cabozantinib arm compared to the placebo naturally. But what was intriguing in that analysis is that for the AFP responders, the median overall survival with cabozantinib was 16 months compared to the non-responders where the median overall survival was 9 months. So understanding AFP response with these systemic agents and the dynamic changes of AFP is going to be an area of further investigation, and it's important to keep in mind going forward.